I want to thank everyone for tuning in this evening and taking the time to hear what we have to discuss. As you'll hear, as Katie Grace mentioned, that we're all passionate about what we do, and we're excited to be able to speak to you this evening. My topic is on resecting the unresectable in terms of pancreatic cancer. In other words, removing tumors that were in the past formerly considered to be unresectable. And just as a little bit of a background, the overall survival, and these are current numbers as of very just a few months ago, is that for all comers with pancreatic cancer, that 13% of people diagnosed today will survive from pancreatic cancer beyond 5 years. And not the best statistics. It has gotten better. It's actually quadrupled in the past say decade or so, and it's still a dismally low number, but I think that there's many things on the horizon that are going to change that, and why that number has dramatically increased over time. And I think that we're going to see that go to something that is much more respectable. The topic that I'm going to discuss tonight is on localized pancreatic cancer. In fact, you'll see that all three presentations are on localized pancreatic cancer, and we're going to be discussing different aspects of that. We're talking about a subset of patients here who have a much better chance of survival, and those are who are diagnosed with localized disease. And I think it's a couple of just simple background things to get into what I'm going to discuss. Is that the only chance for a cure of localized disease is through surgical resection. And in that line, there's 3 points that I want to make in this talk. And I think that the first point will be important for the second 2 talks, is the impact of the operation or the procedure is only as good as the systemic control. And hopefully that'll make more sense as I go through the talk. The resection of locally advanced pancreas cancer is safe and effective, meaning those tumors that were considered to be unresectable previously, that involve major blood vessels. And that ultimately we will develop technical solutions for almost any locally advanced tumor. Now, here's a bit of the issue in getting into the systemic aspect of pancreatic cancer and the operation only being as good as systemic control. This is a study we did not so long ago where we took 500 highly annotated patients and followed them over time and looked at their survival and their patterns of recurrence. In the ones who had recurrence, over 80% of them developed systemic disease. That means disease outside of where the area that was resected, liver, lung, and other sites, with liver being the most common site. So what this says, it's a pretty simple study, but this was known and just underscores that clinically localized pancreatic cancer is not biologically localized. It's systemic disease. And what does this look like, or what does this mean? Well, if we remove all of the gross disease, so we do an operation and we take out the disease, or we ablate the disease, as you'll hear about, the outcome depends on the control of micrometastatic disease. So it's not what we take out, but it's what we leave behind. And what do we leave behind? Well, we know that these tumors will shed cells or release cells that are called circulating tumor cells. These will go into the circulation and go throughout the body. They will lodge in many different organs for reasons that are not completely understood. They most commonly will grow in the liver, that not all of these cells are the same. Some possess stem cell qualities, and we know that these are potential precursors that can establish metastatic recurrences. They leave the primary tumor, they gain access to the circulation, they extravasate or otherwise leave the circulation, and these form these micrometastatic disease. So these small clusters of cells or single cells, no matter what imaging study we do right now, outside of experimentation in animal models and things, we can't see these. We just know that they're there based on the pattern of recurrence. If this systemic disease is not eradicated, we call this disseminated tumor cells. If this is not eradicated, we say, well, the patient gets a recurrence. And that would be clinical stage 4. So it's really not so much a recurrence, it's progression of this systemic disease, and that is the cure to having more cures. So the impact of the operation is only as good as the systemic control. And I just want to illustrate that with this simple example. This is a patient with pancreas tumor in the head of the pancreas, a very simple, easy operation to do. It was a very straightforward operation. The patient went through it, recovered fine, and within 3 months had a metastatic recurrence from this micrometastatic disease. So that operation, although it was a good operation, and the patient recovered well from the operation, the impact of that operation was essentially nothing. They derived no benefit from that operation. Here's the other extreme. Here's a patient that we'll discuss some of these patients that the tumor is wrapped around many major blood vessels, and through some techniques that we will talk about, we were able to get this tumor out. Now, that operation was a very difficult operation, but it really had very little to do with the prognosis, because once the tumor was removed, the last time we studied this patient, they were alive without disease at 4 years. And so the impact of that operation, although big, was huge. So why do I bring that up? Well, we're about to talk about some aggressive operations. And it's not so much that these are technical achievements. What allows us to do these operations is that we now have better systemic control. We have more patients with clinically localized disease, and we probably have better biological localization of disease. And so it makes sense to do more aggressive operations, because we could put more patients at the chance of a cure, or at least extend their survival. So now moving into the meat of the matter is resecting the unresectable. What is considered to be resectable or removable when it comes to vessel involvement? Well, there's some highly recognized and established guidelines called the NCCN guidelines for staging. If the tumor is localized and that has not spread, no vessel contact is stage 1, stage 2. If it mildly involves a vessel, that would be stage 3, borderline resectable. For years, we've been resecting those tumors. There's nothing controversial about that. Yet there's a subset of patients who have no worse disease than those other 2 categories, but just by the nature of where the tumor has grown, the operations are more complex, and they were considered to be unresectable. And we're going to go through a little bit about how these tumors can now be resected. And this is not just something that has changed in surgery. The whole field has grown. As I mentioned, we have better systemic control through multi-agent chemotherapy. We have targeted types of radiation that now are more precise and we feel are more effective, that are adjuncts to local control and local surgery. And we have outstanding imaging such as this. Every patient now, we do 3-dimensional reconstructions, and we have basically our own textbook of every patient, and we know the anatomy before we get in there, so we can plan much more complex operations. So there's 2 main categories of vessels that are involved: the main arteries, celiac trunk distribution, and SMA distribution. And we'll go through some of the tumors and some of the techniques that can be used to now remove these vessels. It used to be considered that encasement of the common hepatic artery was unresectable with involvement of the celiac trunk. However, we know physiologically that if you clamp the celiac trunk in the so-called Appleby procedure, you can get blood flow retrograde to the liver so that you don't necessarily need the celiac trunk. So in these isolated tumors of the celiac axis, we borrowed an operation from gastric surgery called the Appleby procedure. We modified it in several ways. The details are not necessarily important here, but beyond this discussion. And we realized that there was a group of patients that we formerly felt were unresectable that we can now resect. And this is an example of such a patient that you can see the entire tumor is removed. Here's the aorta. It's completely skeletonized. There is the stump of what used to be the celiac trunk. There's the GDA with the flow going backwards. And you wonder, well, how can there be, is there really enough flow? And you can see this is the cut edge of the common hepatic artery, and that flow is all coming backwards and supplying the liver. So that operation was one of the first operations that we did on locally advanced, and it became sort of standard. Now it's something that we do quite often, and probably one of the simpler operations, and the outcomes were good. So then we asked ourselves, why would the GDA be the determinant of whether or not something can be removable? Because even if the GDA, which supplies that retrograde or backwards flow blood, is involved with tumor, we have a way to reestablish blood, and that's through reconstruction. And here's an example of a resected common hepatic artery where the GDA is out. And so there's now no flow to the liver, but it becomes a quite simple thing to hook up this connection with this connection and provide forward flow. And here, in fact, is not that example, but many examples we learned is that the inflow for the blood vessel is really not an issue. It's, do we have a target to sew to? And if we have a target to sew to, we can take blood from just about anything. Here, we completely took the celiac trunk. It was down on the aorta. And so we found blood supply from the right kidney artery, right renal artery, and used a piece of saphenous vein in reverse with a natural bifurcation and took it all the way up and connected it to the right and left hepatic arteries. So a technical solution to a patient who had good biology in reconstructing the artery. And here you can see on an arteriogram, it's in the same orientation as the patient. You can see the blood supply to the kidney. We borrowed some of that blood supply and bypassed the tumor, took out the tumor, and took the blood supply from the right kidney artery to the liver. And in fact, you can take blood from anything, the iliac artery, and take it up to the liver. Here we jumped it off of the splenic artery and used a saphenous vein graft to take it to the liver. Here we actually repurposed an artery itself. This was formerly the splenic artery, and we borrowed it, or not borrowed it, we're not going to give it back. We took it and jumped it to the arteries. Now the blood supply is coming through a native splenic artery, but instead of supplying the spleen and the tail of the pancreas, is now supplying the liver. And so we realized that and here's the celiac trunk, that these tumors that involve the celiac and the hepatic artery that used to be unresectable, we have very safe and effective means to get past the tumor involvement of those vessels. But one of the things that we learned is like, okay, well, now we should be able to resect just about anything in the celiac trunk. But as I mentioned, the inflow is never an issue, but the outflow. You can only sew to a vessel that is so large. And so we wear loupes and magnifications, but even then there was a limitation. So how do we push the limit of this even further? So we partnered with our microvascular colleagues. And this picture here, these vessels look big, but this is actually done under the microscope. These vessels are millimeter-sized vessels that it would be next to impossible to do safely without doing the microscope. And so now we can chase these targets further and further up onto the hepatic arteries so that it puts more people with good biology who've gotten chemotherapy up front in a position of a cure and extending survival. And again, a lot of this, you can see that those distal targets are relatively small, but again, here we jumped it off of the splenic artery. Getting inflow is never an issue. Now we turn to the SMA, we realized that, okay, so the celiac trunk, we can deal with a lot of those and put a lot of more people into play for a resection, for an oncologic resection. The SMA historically there's some difficulties with accessing the SMA with a tumor, and also the stakes are a little bit higher in terms of the bowel is more sensitive to ischemia. But again, the techniques are the same. And so then we began to tackle the superior mesenteric artery resections. And what used to be considered to be unresectable was encasement. And to make a long story short, as we started to explore this and look at patients and start to resect them, really there's two types of encasement. So when you look at a CT scan report and it says encasement, that doesn't necessarily mean a cancer has grown directly around the blood vessel. This is one of the things that we learned. If you do 3D recons and you look at the vessels and there's no impingement of the lumen, this is perineural invasion, and we call it the halo sign. And this is dissectable off. It's not contiguous with the tumor. It's perineural invasion. And here you can see some tumor, which is in the perineural sheath, intentionally left on the vessel. I mean, of course, we removed it later, but it's just to show the comparison of this clean vessel that there's really no tumor involvement. And this is something that doesn't require a reconstruction of the SMA, that you can simply take these tumors out. So there was patients in the past who we weren't resecting these tumors because they had so-called encasement. But as you can see here, that artery is not involved. This perineural sheath is lymphovascular invasion and microvascular, perineural invasion, and it's easily dissected off. And you can see there's a real nice plane there that this gives a clean dissection on the artery. And what plane are we moving? So this is not contiguous spread from the tumor, but this is a perineural sheath that's removed, leaving the vessel intact, and there's no vessel invasion. We can often predict this up front, but it's also something that we need to be contented to deal with in the operating room. If we start to dissect and we find invasion of the vessel, then we need to be prepared to do a resection. This is just another example of what that perineural sheath looks like. Here's a partially divested SMA. This is from the left side. That's the uncinate process, and you can see this perineural sheath around here. That's not tumor-bearing perineural sheath. And in fact, this tumor was really nowhere close to this vessel, but you can see what a divestment would look like and what the sheath would look like. So that's not part of the vessel. And you can see those planes. When you look at this stuff under the microscope, it's not direct tumor, it's microvascular invasion. Now you get another report and it says encasement of the vessel. Well, there's a different level of encasement, and this is invasion of the vessel. And you can see on the right-hand side on the 3D recons, you get a so-called string sign. That you pretty much know is not going to dissect off. And there you need to be prepared to replace and reconstruct the SMA. And this is now very feasible and can be done safely in that that vessel, which used to be the SMA, there can be replaced by an artificial graft in the arterial position. They're very safe to use. This is a PTFE graft that is rings on it to support it. Here's an example of taking the splenic artery and repurposing it for something else and using it as an interposition for the artery. The best graft that we can use, if it's feasible and not involved with tumors, is an autologous vessel. So in other words, borrowing a vessel from another part of the body. And again, just like we did for the hepatic artery, we found that we could swing the splenic artery down and reconstruct the SMA. And so, you know, that actually put a lot more patients in bounds for a potentially curative resection, making more patients surgical candidates, and thus a possibility of a cure and extending survival. Now, on the other side, on the venous side, portal venous involvement, that was some of the first things that we tackled, and this is we've been doing for years, a straightforward vein involvement with the confluence, being right at the confluence of the SMV, portal vein, splenic vein. That is something that is relatively straightforward to do. And we've come up with many different ways of reconstructing that. And here's an example of what would be a straightforward vein resection: portal vein above, SMV below. And here we harvested a piece of left renal vein and use that as an interposition graft. There's a segment of left renal vein. Now, this is the problem. It boils down to plumbing. If you have a pipe above and a pipe below, and you can put the two ends together, you can fix it. The problem starts to arise when you have these collateral branches. If you would imagine you cut on one side here, you have multiple branches, and you cut on the other side, you have one branch. There's some technical issues with putting those things back together. This is necessary for life. The vein flow through the portal vein is necessary to supply blood to the liver, and it's also necessary to decompress the bowel. And part of it was being able to get down onto the vessels, and we used to think that you had to clamp one vessel at a time, but you can see that we had dissected out to the level of the mesentery. We were able to dissect 3 different vessels out at the base of the mesentery, individually control those vessels, and then it became quite simple to reconstruct that. But it became more complex as we had to go further and further down. And it was simple. Well, why not just sew in smaller grafts? And we can do that, but there is a limit to the size of the graft. We know, and it's beyond this talk, is that you need a certain amount of flow through these grafts to keep them open. But if you're above that flow, you know, you can begin to bypass smaller and smaller vessels. And often it's not just one vessel. You can see here, we're tapping into the portal vein, but this is a bifurcated graft coming from 2 different vessels on the other side of the patient. And they, you know, had enough flow in them that they would stay open. We don't always need to send all of the blood supply to the liver. We used an old technique called a mesocaval shunt. If there's a portion of the bowel that needs to be drained, We can sometimes drain that directly into the vena cava, and people do not get hepatic encephalopathy because they still have plenty of flow. It has you not necessarily recompromise the portal vein, and it's a relatively safe way of decompressing the bowel. And you can see that mesocaval shunt there, which was cryopreserved allograft. Now, this was sort of the ultimate in reconstructing vessels, and this is cavernous transformation, where the entire portal vein is out and you have multiple collaterals. There's multiple technical aspects with this, but one of the technical aspects was, as you were taking out these tumors, which takes hours, and you're tying off of these collaterals, you basically are slowly choking the blood supply to the liver and to the small bowel till you get down to the point where you can get the specimen out. Here's another example of that right here, but the thing that we thought about is like, well, can we just bypass this at the time of surgery? While we do the operation, we take blood from below and return it to above with a graft. And here's an example of doing that. This is a large tumor right here, the head of the pancreas. This is going to require taking down numerous collaterals, and it's going to take hours to get down to do an oncologic safe resection, and the liver and the bowel won't tolerate that. So while we're doing that, we put in a temporary shunt. This is left IJ to a Dacron graft back to the portal vein, so the blood is temporarily bypassing the tumor while we take it out in essentially a bloodless plane. This graft here then stays for permanent, and when we're done, we remove the artificial graft and swing this up and put it to the portal vein. But it turns what was an impossible operation into actually, not that difficult or bloody of an operation. So the question is, what is resectable? Well, we will develop technical solutions for almost any locally advanced pancreas cancer. We're in the middle of this evolution, and I'm certain that we will find technical solutions. We've discussed this a few times. Your entire aorta can be replaced. It's a technical problem. We can actually replace the aorta with something called a Caselli graft. Probably the limitation ultimately will be low mesenteric vessels. But that really puts many more people in bounds. So what can we resect from anatomy? What we should be thinking about is what should we resect? It gets back to biology and systemic control. We need to switch from anatomy to tumor biology. Now, that's a topic for a whole other talk, and that's where the field is moving. Now, just because we can do something doesn't mean we should. What are the outcomes? Are these patients doing well? This is a series now. My slide needs to be updated. I think this was published now in the Annals of Surgery a year or so ago. But if you look at the outcomes, the significant morbidity is no different than a straightforward Whipple operation at about 50% morbidity, which is typical. Same types of complications, meaning delayed gastric emptying, pancreatic fistula being the most common, wound infection. The only thing that's a little bit higher really is chylus leaks. The mortality, right now, the mortality in the surgeon's hands here at this institution for a straightforward Whipple is less than 1%. Here it's 3%. It's 3 times higher. Certainly not where we want to be, but we think a reasonable mortality for such an operation. And you can see that the R0 resection rate is almost as high as 90%. Now, I'm sort of more a visual kind of person. Of course, I'm very much data driven, but sometimes a picture is worth 1,000 words. What do the patients look like after an operation like this? And, is something like this, is there any long-term survival? And these are, of course, people are going to pick their best examples. I mean, people, I won't kid you, it's tough to recover from this operation. But these are 2 examples that just came to me. The first one on the left side was a patient we did one of those triple vessel resections that you saw. And this is her on video post-op visit 2 weeks after discharge. And you can see, I mean, she's certainly not back to normal, but she feels well and does not regret going through the operation. Okay, so that's great. So she did well in the short term. Can anybody live, long term with this? This is an example of a patient I had done at my former institution. And he had a multivascular reconstruction. I just heard from one of my colleagues over the weekend who saw him at a PanCan. he's now 6-year survivor from one of these major operations. And so both the data and both anecdotally, it tells us that I think we're doing the right thing and that we are increasing the number of people who have a chance at survival. So I would conclude by saying resection of locally advanced pancreas cancer is safe and effective, not only feasible. So to summarize my 3 points, the impact of the operation is only as good as systemic control. Resection of locally advanced pancreas cancer is safe and effective, and we will develop technical solutions for almost any advanced tumor, and that, you know, the anatomy is just a plumbing issue. And as surgeons, we will be able to overcome those plumbing issues. When we get better systemic control, which is getting better and better all the time, and we understand how to select the right patient, the impact of the operation will be huge, and it'll be worth doing these types of things. So I want to thank you for your attention. Thank you once again for joining in. And it's, again, an honor to present to you, an honor to be asked to present and to present with this very prestigious group. And also on behalf of our NYU group of surgeons, who of course, I'm biased, but I think, you know, this group of HPB surgeons really are going to determine the standard of care in the future. And it's great to be able to work with them. So thank you.
Thank you so much, Dr. Wolfgang. As a reminder to our audience, you can submit questions at the bottom of your screen at the Q&A box. Our first question is, can very small pancreatic cysts become tumors? And if so, what are the chances?
Yeah. So pancreatic cysts is a great question. You know, it's something that's very, very common. Every year, because of CT scans, about 500,000 new patients are diagnosed with pancreatic cysts. It's sort of a disease of modern medicine. They've always existed, but we only started looking at them. Now, there's nowhere near that many new cases of pancreatic cancer a year. And as we looked and started to understand these cysts, first of all, the cysts are not all the same. A large number of these cysts, so for example, serous cystadenomas, they are pancreatic cysts, they are cystic neoplasms, but they are completely benign. If we knew 100% that that there was a serous cystadenoma, we wouldn't even need to follow it because there's no cancer risk. There's a subset of cysts that are called IPMNs and MCNs. They're mucin-producing cystic neoplasms. And of themselves, they're precursors to cancer, very similar to a polyp in the colon. You've heard of somebody, or you've gotten a colonoscopy, they find a polyp in the colon, they pluck it off, it's benign, no big deal. These things are the same way. The only problem is that we have no way to just pluck them off. We either watch them or we take them out, which is a big operation. And so the vast, vast majority of these we watch. And based on characteristics, based on imaging, based on EUS, based on demographics, we can often, with a pretty good degree of certainty, decide which type of cyst it is. If it's one of these mucinous cysts that needs to be followed, we have very strict criteria on how we follow them. If they don't meet those criteria, the risk of malignancy or impending malignancy in that cyst within the next couple of years is actually very, very low. It's essentially zero. They can be watched. The ones that are on the border or meet those criteria, they should be resected. But the fact is, the vast, vast majority, probably over 90% of these can be watched. And there is an older study now. It's Peter Allen published it when he was at Memorial. He's now down at Duke. But he looked at and estimated the 10-year risk of a non-concerning cyst progressing, and it was only about 3%. So in other words, if you take 100 people with small cysts that don't meet criteria, can they progress? Yes, but the chances are they won't. Now, the thing is, are you one of those 3%? Are you one of the 3 of the 100 who will progress, or one of the 97 who won't? The problem is right now we're not very good at being able to dissect those apart, and so we have to follow all 100. So yes, a small cyst can progress, but it's unlikely. But the key is, big or small, whatever, it should just be followed by an experienced group, and the key here is just systematic follow-up. It's safe. I mean, when it's done by an experienced center. there's only, several centers in the United States, and even only several centers around the world that really do it with any sort of routine nature, where they do it at a relatively common rate. And so if you're in one of those centers and you are appropriately selected and planned, and you're felt to be a candidate, then yes, it's safe. It's not zero risk, but the risk benefit ratio is in favor of having the resection, because the benefit of resection outweighs the risks. And it's not only about the risk of mortality, it's also everybody goes through a period where you have to recover. And even in the best case scenario, it's not easy. Tired, washed out, lack of an appetite, losing some weight. I mean, it ultimately gets better, but there's that impact too. But that is outweighed by the benefit of surgery. But again, it has to be done at a center where they do a lot. Even a so-called straightforward Whipple is still a huge operation. And when that's done at a center where the volumes are not high, the mortality rate goes up, let alone trying to tackle an arterial resection reconstruction. Well, first of all, the operations are big, and even, it's not age. I mean, we do these operations on 70, 80-year-olds. But you have to be in good shape. So it doesn't mean you have to be an extreme athlete, but you have to have the physical ability to tolerate the operation. And what that really means in practical terms is that if you're capable of your activities of daily living, so meaning you get up in the morning, if you work, go to work, if you play golf, care for yourself. If you can do that, I know it doesn't sound like a fancy test, there's a very good chance you will tolerate the surgery, first making you worse before we make you better. In terms of the second most important thing, it has nothing to do with the anatomy. As I pointed out, it has to do with the tumor biology. Nobody should undergo a resection like this without a period of chemotherapy, multi-agent aggressive chemotherapy, systemic therapy, FOLFIRINOX, Gemabraxane, or something tailored for your tumor type. And on chemotherapy, we have to demonstrate that there's good biological control. It gets back to that systemic disease. We have to demonstrate that we have a drop in CA19-9, that there is a regression of the tumor size, or at least a stability in the size, and that you're tolerating the chemo. If those basic things are met, then you are a candidate for surgical resection. It gets back to the plumbing where the nuances are. A tumor can be resected off of any vessel, or any vessel can be reconstructed, as long as we have a distal target to sew to. And that seems like a vague thing, but that's the bottom line. Inflow is never an issue. And it's the same way on the vein. It's all about the targets. If we have targets to sew to, we have technical solutions for many different types of things. After an operation like this, people are typically in the hospital between 7 and 14 days. And pain is not the main issue. Probably the single biggest thing is the ability to get back on a diet. Eating is difficult. You don't have the best appetite. You eat because you need to eat, but you fill up quickly. And that doesn't completely go away when you leave the hospital. People, it's a bit of a struggle to get in the calories. It's high calories, relatively small meals, but frequent meals, and that goes over time. The second thing is that you would think, wow, this is very, very painful and things like that. I mean, yeah, you're going to be sore after surgery. You're going to know you have an incision, but pain is not, and this is obviously, I've never gone through one of these myself, but have seen hundreds and hundreds of patients and thousands of Whipples who've gone through this. Pain is seldom something that people complain about, but tired and washed out. And so I always will tell people that, you go home, you wake up in the morning, you feel like $1 million by 11 o'clock, you're ready to go back to bed. That is the price sort of to pay up front. And it's not a permanent thing, but it's a struggle to get back. It's almost like training for a sport. You have to push yourself to get your strength back. You have to, work with the eating and the diet to make sure that you're getting calories on. Usually around 2 months, around 1 to 2 months, that's the period you're like, oh man, why did we do this? Sometimes people will say that. And then around 2 months, you say, okay, you know what? I don't feel 100%, but now I see the light at the end of the tunnel. I see the benefit. I'm glad we did it. And usually between 3 and 4 months, people should get back to a pretty normal lifestyle. You're not going to have drains. You're not going to have tubes. You're not going to have physical restrictions. You're not going to have dietary restrictions. And, you know, having done this now for 20 years, I have patients who are 5 years out, 10 years out, 15 years out, and they struggle with the same thing that anybody else struggles. I have Whipple patients who are on diets and on Ozempic or the GLP-1 inhibitors to try to lose weight. I operated on a young gentleman who played with a neuroendocrine tumor, obviously long-term survivor, who went on to play junior hockey after his Whipple in Europe. And so, you know, there is life after it, but I won't kid you, there's certainly something to go through up front. And again, the question is, why go through that? Well, the benefits of the operation outweigh the risks. If there would, believe me, if there would be a better way to do it, and I admire my patients and their strength that to go through this and fight and recover. You know, they're inspirations to me, and I know it's tough. I wish there'd be another way, but it's just that right now in the current sort of treatment methods that we have, it's the cost of doing business, and you know, people do get through it. All as I can say is our team is there with them to help people through it. You're not on your own. That's actually something that is a little bit of a, how do you say, it's been propagated, but it's not true. Actually, Colin and I work together hand in hand. Radiation is a tool, and sometimes it's a very important tool and adjunct to surgery, and it's required. If you have a borderline resectable tumor where it's close to an artery, but it doesn't encase the artery, the radiation is very helpful. It doesn't really make the operation any more difficult. It doesn't make it any easier, but what it does do is it helps us achieve a negative margin. And so I will send a lot of patients for radiation. It should be a determination that is made by your medical oncologist, your surgeon, your radiation oncologist together to come up with a plan. It's sort of like everybody's a little bit different, but radiation is actually very important in some individuals. Where it becomes a relative problem, but we look at each one of these cases. If somebody has gotten radiation, they didn't realize they were a surgical candidate, and now they want to, you know, have surgery, and it's wrapped around an artery that we have to reconstruct the artery. I mean, it can be technically achieved, but the artery becomes brittle from the radiation. And even when we get the artery together, the artery is a high pressure system. And over time, it can bulge and form an aneurysm. It's really a pseudoaneurysm. And the risk of the vessel blowing out after high dose radiation to one of those vessels is a bit higher. So it's not like radiation is evil. It's not like surgery. The two go hand in hand, and they quite often complement people. I probably have operated on more people with vessel involvement using radiation as an adjunct than not, but it just has to be done selectively and case by case. So just because you had radiation doesn't mean you can have resection, and doesn't mean it makes the resection more difficult. In terms of veins, it doesn't matter if it's just venous involvement. Those veins will tolerate being in a radiation field and being reconstructed.
Just add to that, Chris, two important points. The important point is that, you working together with an experienced team. So, Dr. Wolfgang and Dr. Hewitt, have experience on operating on patients after radiation. So we often, work together where we make sure that after the radiation, they get the scans in about 4 weeks, and then they're operating within 6 to 8 weeks. So, Chris can comment more on this, but the scar, formation at that point is not as significant as if you're going to wait longer than that. And, as a radiation oncologist, this is something I pay attention to when I'm trying out the tumor volumes. We'll talk more about this, but now we're trying to push the radiation doses higher and higher. And we've seen in some trials recently that when you push the radiation dose really high, especially to the arteries, there can be potentially some vascular complications. So this is something we're trying to be mindful of. And the challenges with delivering radiation right now is that we don't have the right tools to be able to see the tumor every day during treatment to track the arteries. So we're trying to change that now, and I'll talk more about that. We don't have much slides up.
Thanks, everyone. I appreciate, again, you guys taking out the time especially during the week. I know it's later in the day, so we really do appreciate you guys participating, and feel free to keep the questions coming. I'll certainly leave some time at the end as well, because I'm sure there'll be a lot about histotripsy and robotic surgery here. So again, we'll go over kind of a couple things. Chris talked about a lot on the pancreas cancer side here as far as from the background, so I'll just kind of provide some supplemental slides for that. And then we'll spend most of the time just focusing on robotic surgery and then histotripsy in the setting of oligometastatic disease. And we'll describe both what oligometastatic disease is, as well as what this histotripsy technology is all about. And so again, pancreas cancer, it's the 10th most common cause of cancer, but it's the 3rd most common cause of cancer death, unfortunately. And so it's one of those that it's not as near as common as many others, but it can be quite lethal. And part of that is because most of the times we discover it, it's already spread throughout the body. So 50% of the time we find patients with pancreas cancer, unfortunately, it's already spread throughout the body. And that doesn't mean we can't help. And that's what I'll get in about oligometastatic disease. But it certainly does mean that the tumors tend to be more aggressive before they end up causing problems. So before we can actually detect them. And again, as Chris highlighted, and I think you can't talk about this you can't talk about this too much, in that surgery and chemotherapy and radiation therapy, for that point, are all complementary. But it certainly does all survive around chemotherapy. You need to demonstrate that disease can be treated, because we do believe this is a systemic disease from the beginning. So even if we can't see it, we still believe that there are cells that are around the body that chemotherapy will ultimately need to take care of, whether that's before or after surgery. There's certainly some debate about that, but certainly do need at least surgery and chemotherapy, okay? And it's the advances in surgery, chemotherapy, and radiation therapy that have really started to extend life in patients with pancreas cancer. And so this graph here kind of represents that over time. So you talk about over 20 years ago now, and our outcomes were in the low single digits. This is overall survival for 5 years. And certainly in locally advanced disease, we've really picked up here. But really in all stages of disease here that you can see is that, regional and distant disease. And we've really gotten a lot better as the chemotherapies have gotten better, as our surgical techniques have gotten better, as our ability to focus radiation therapy has gotten better. Our patients have done much better. And so just as kind of a 10,000-foot view in terms of what we do with the pancreas, we like to try to keep it really simple, although, Dr. Wolfgang's slides probably go into some of the really complex things. When it comes to pancreas surgery for cancer care, we rather remove the front of the pancreas or we take out the back of the pancreas. And that's it, really one of two options. And so the Whipple procedure talks about when lesions or cancers are in the middle or the front of the pancreas, and that's that yellow organ here in the back that you can see. And so the Whipple procedure is the more complex of the two by a lot, and it's essentially broken into 2 parts, where we do the resection. So we remove parts of 3 organs. We take out the head of the pancreas, we take out the intestines and sometimes a part of the stomach, and we take out the bile ducts, and that's that tube that leaves the liver here. And so because you're taking out parts of 3 organs, you have to go ahead and reconnect everything. So then we make 3 connections: the pancreas to the intestine, the bile duct to the intestine, and the stomach back to the intestine. So it's those 2 phases of this procedure. And then when we're talking about a distal pancreatectomy, that's where we remove the back end of the pancreas. And when we do that for cancer care, the vast majority of the times, we're also removing the spleen with that. And the reason for that is a couple things. One, there's lymph nodes that are associated with that we need to get to remove to help tell us how advanced the disease is, but also there at times can be some benefit to that in terms of how to direct therapy afterwards. And also because the vessels are really intimately involved. Now, I'll go in a little bit later and talk about how you can actually still remove tumors from the vessels and things like that in the appropriate setting. But oftentimes we take the end part of the pancreas and the spleen together, along with some of the surrounding lymph nodes. So Dr. Wolfgang talked about pretty extensively what we do open. And so what that means is very traditional, and we do that a lot here as well, as we make a large incision in the abdomen and we go ahead and we take out the mass itself, and it's been done that way for almost 100 years now. And so with the advent of a robotic surgery platform, we've been able to really kind of modify procedures through much smaller incisions by doing the same procedure just on a much smaller scale. And so what is robotic surgery? There's a lot out there now, and really, well, what does that mean? And this is really what you hear in the news now, is between AI and self-driving vehicles. The thought is that, robots just go on their own, and so the surgery happens on its own. And it certainly is not like that. So in robotic surgery, things only move when we move them. So this is what a couple of the robotic platforms look like. And you can see on the left side there are some surgeons at what we call the console. And so we're controlling it there. And then the patient's bedside's about 10 feet away or so. This is a pretty standard setup. This is how it is in our operating rooms. So you can see the robotic arms are by where the patient is there in green, under some sterile drapes. And then we're off to the side very close if anything happens, but we're off to the side and doing the procedure that way. And so again, the robot, it only moves when we move it. It does not do anything autonomously like that. And there's a number of different platforms that are available to perform these surgeries. So what are the benefits? Well, there's a number of them. So on the left-hand side here, so the most important thing is that, folks are able to get back to their life faster. And so, again, as Dr. Wolfgang mentioned, you certainly do take a hit in the short term. And by that, what we mean is, you're much more lethargic. It's difficult to eat and drink at times. But really, just being able to get on with your daily life at the beginning can be quite challenging as you recover from that. A lot of early fatigue and things like that. What we know, when we compare the same types of surgeries, whether it's open versus robot, we know that patients that get it done robotically, on average, are much quicker in terms of their feeling normal again, or they're getting back to their preoperative level of activity. In addition to that, they leave the hospital early. We've had a number of patients now leave the hospital 4 days after surgery, which really before robotic surgery was almost unheard of. The average stay is anywhere from 6 to 7 days. Some high volume centers like ours can get patients home after 5 days. And then with robotic surgery, it allows us to move it back up to 4 days for some folks as well. There's, for us, less bleeding in the operating room. There's less pain post-op for patients. So most of the time with open surgeries, we do things like epidurals and other adjuncts that will help relieve pain post-op. We don't have to do that with robotic surgery. And so what we find oftentimes is over half the time, patients don't even go home with pain medication. They go home and they just take Tylenol, ibuprofen, and that's really it. They don't take narcotic pain medicine. And that's great because narcotic pain medicine has a ton of side effects. Obviously, that's been in the news for a decade now in terms of the side effects of narcotics and how that can be debilitating. So it's really great that we can send patients home from really this complex procedure with really minimal pain medications. Also smaller incisions, which is kind of the least of our worries, but certainly if we want you to be long-term survivors and things like that, we want it to look good for as long as we can. And then, as I mentioned, there are certain types of cancers, although most pancreas cancers are of adenocarcinoma type, which is the more aggressive type, which tends to go to lymph nodes quite early on. And in those situations, again, we rarely ever, if ever, will leave the spleen. But in some other types of pancreas cancer that are less aggressive, like certain very small neuroendocrine tumors, we can save the spleen for individuals. And so that's much easier to accomplish when you're doing it robotically, for example, compared to something like laparoscopy. And some of the downsides are really not so much for the patients, but really more for us is on average, it tends to be longer operating times. A standard Whipple is usually around 4 to 5 hours. Robotic Whipples on average are around 5 or 6 hours, although in our center here, we do ours usually about 4.5 to 5.5 hours. So that's usually about where we are. So we're making good progress there on time. But for the patients, it's, you fall asleep and you wake up. So it's essentially 1 or 2 seconds. Right now, we're a little bit limited in terms of doing some of the work that Dr. Wolfgang mentioned. We can't yet do that robotically, although we are making strides to do that. There are a couple centers across the world that have attempted to do so and have done so successfully, and most importantly, have done so safely. And so we are about to embark on that as well. But most importantly, there's equal cancer outcomes. So whether you get it robotically or whether you get it open, your ability to survive long-term is equivalent. So there's no difference. So getting it done robotically is not an inferior surgery when you're talking about cancer outcomes. And so here's a couple pictures of what it looks like after robotic surgery. So on the left-hand side is for these Whipple procedures. So you can see the biggest incision people get is about 2 inches or so. And that's just because we have to get the specimen out. So we do have to get the disease out of the body. And so it does have to be at least a couple inches. But otherwise it heals up. And this is immediately following surgery. So these actually fade over time and can be quite small. And you see on the right there is those are distal pancreatectomy. Those are much smaller incisions as well. And there's generally fewer of them. And so again, not that this is the most important thing in the world, but we pride ourselves in, and again, having our patients do well and feel well after surgery, and small incisions is a big part of that. And so at NYU, how do we stack up? Well, in the last 12 months, we've done over 40 robotic Whipples and over 32 distal pancreatectomies. Nobody has died. Most importantly, where folks have done generally very well after the procedure, like I mentioned, going home early, getting quicker in terms of return to recovery faster. And so how does that stack up compared to other institutions? We are the busiest pancreas program in the Northeast. So there's good and bad about that. Bad that we have to do so many, but good that we're able to do it. And it's not just us as surgeons, but it's our whole team. This is a complete team effort from the surgeons to the nurses to the nurse practitioners and the radiation oncologists, our interventional radiology colleagues as well. So we all function together as a very busy team. We're number 4 nationally in terms of how many we do and how good our outcomes are. So we're very proud of that point. So oligometastatic disease. So this is talking about what we're doing is, we mentioned local regional disease, so disease that has not visually appeared to be other places. Again, we do at a cellular level believe that the disease is in other places, but what we want to see, is there anything on imaging that has spread outside of the pancreas itself and gone to the liver, gone to the lungs, gone to the peritoneal cavity, the other locations? And we think this happens in kind of a step process in the sense that some cells break off, and as Dr. Wolfgang mentioned, they settle into an area, to a specific organ, and then they start to multiply there over time for any number of reasons. And so oligometastatic disease specifically, how is that different than widely metastatic disease? Well, oligometastatic by definition means one of two things. It means that there is a level of disease that can be treated definitively, which means there's disease in other areas, but it means we can rather remove that disease or we can treat it definitively, meaning we can ablate it or burn it, or use histotripsy, which we'll talk about here in a second. And then secondly, the hope is that by doing this and by being a little bit more aggressive when it comes to treating these lesions, we will most importantly extend the patient's life. And so as you can see here, there's synchronous disease, which means disease that is found at the time of diagnosis. And then there's something called metachronous disease. And metachronous disease specifically talks about after you remove the primary disease, essentially disease recurrence, like in the liver or in the lung, months to years down the line. And so when we talk about, well, how do we deal with these types of diseases? And a lot of this has actually come from colon cancer. And over the last 20 years, there's been a lot of progress made in colon cancer. And it's gotten to the point now where even a liver with multiple sites of disease, if you can treat that disease, again, proving good tumor biology, meaning you give them chemotherapy and they're stable over a period of time, you can go ahead and be aggressive and remove that. And actually in colon cancer, half of patients that have disease in their liver can live over 5 years. And it used to be that number was in the low single digits. So we've made a lot of progress with systemic therapy. And so to mirror that model in pancreas cancer, as our systemic therapies have gotten better, as our chemotherapies have gotten stronger, as our surgical technique has gotten better, we're able to be more aggressive in appropriate patients. Ultimately, biology is king. So if we give somebody chemotherapy and we see over time that their disease progresses, then those aren't great candidates for being more aggressive in, because all we're going to do is really hurt you in the short term, and we're not going to provide any of that long-term benefit. Remember, a big part of oligometastatic disease is the fact that there's an underlying implication that you can extend life on the back end. And so again, the whole point is we want to be able to treat all the disease we can see. Chemotherapy is the backbone of this. You need to prove good tumor biology, meaning there's no worsening of disease, and ideally there's some shrinking of the disease. And that's not just visually, but also chemically. So we talk about markers that are tumor markers called CA19-9. That's the most common one we track in pancreas cancer. And then when it comes to, well, how do we treat these? We want to treat them definitively, which means we want to rather completely remove them if possible, or we can irradiate them with high-dose radiation, and Dr. Hill will talk about that, or we can ablate things. And there's a number of different ways we can do that, and histotripsy is one such technology. So what is histotripsy? Well, so histotripsy is taking focused ultrasound waves that mechanically destroy tissue in a process called cavitation. And so what happens is when you focus these ultrasound waves, microbubbles are created on a cellular level, and they oscillate up and down really fast in a very small area. And what it does when it oscillates up and down, it essentially breaks up that tissue. So it essentially destroys the cells at a cellular level, and it doesn't use radiation, and it doesn't use heat to do that. And then what happens is what's left over is something called an acellular debris. And then that ultimately will get reabsorbed by the liver. And that may have impacts also on the immune system of the liver, which I'll talk about in a little bit. But this is the Histotripsy device. And so what this is that's the patient laying on the bed, and there is essentially a canister that sits on the patient, and the device sits in that, and it uses the ultrasound waves that way. And we use an ultrasound, so it's ultrasound guided ultrasound waves is how it's managed. And so this is the way it works. So you shoot in the ultrasounds from a couple different directions, and it focuses in on the lesion, and it creates these small bubbles, and these bubbles go up and down, and they end up destroying the cells. And then you're left with this cavity here. And this cavity, what is in that is what we call acellular debris. It actually looks like a little bit of mush almost. And then the liver itself will reabsorb that. And so it is FDA approved as of late last year. To treat rather primary liver tumors. So it can treat a primary liver cancer like hepatocellular carcinoma or a cholangiocarcinoma. And it can also be used to treat lesions that spread to the liver. So in pancreas cancer, like we mentioned, the most common place it spreads is to the liver. So if we have isolated liver lesions or, one or two liver lesions, then we can use histotripsy to treat those lesions. Also colon, breast, and any number of them as well. And right now, it's just approved for treatments in the liver. There is an ongoing trial to start to treat lesions in the kidneys. And then in the future, we hope as long as this technology stays safe and stays effective, there's hopes that it'll be able to expand to primary lesions in the pancreas and primary lesions in the breast as well as other sites. And so this is what I was talking about when after the tumor itself is treated and that acellular debris is left there and the liver will go ahead and absorb it. What has been shown in a couple patients, and this is really a really fantastic effect if this is proven out over time. Now, again, less than 150 patients have been treated with histotripsy total. And we've done multiple here at NYU, but I'm talking in the whole world, less than 150 patients have been treated that way. And so when we're talking about treating these patients here, we focus in that ultrasound, and that acellular debris gets absorbed over time. And what happens is that acellular debris elicits an immune response from the liver, from the entire liver. And what it essentially results in a small percentage of patients, about 10 to 15, we think right now, but we're still certainly learning, is that the liver now more effectively fights the other lesions in the liver. And that's called an abscopal effect. And so again, there's some early evidence for this. By no means is it completely proven yet, and certainly by no means does it happen for every patient. But we are seeing it with histotripsy at a much higher rate than we've seen it with pretty much any other technology to date. And so these pictures here show that, is that particularly in this D picture here, is that these lesions, although they haven't completely gone away, they have certainly shrunk in size. And that's really critical as we start to understand this process moving forward. And so here's our first patient. This is Chrissy Martinez here, and this is Dr. Wolfgang together. And it's part of our team that has treated her, and she's doing very well. I believe she is actually on the Q&A here. And so Chrissy, if you're listening, you've been a pleasure to take care of, and I'm so glad you're doing so well, and we hope it continues to do well. And so kind of in summary of all these things here, a couple of things I want to highlight here is that, robotic surgery, for the vast majority of patients that are able to get surgery, is an option. Not at every center across the country. We are one of the higher volume centers in the country, highest in the Northeast when it comes to pancreas resections. And it's a benefit to the patients. Less pain on average, smaller incisions. You get back to normal life faster. Get back to chemotherapy if you need that as well. And most importantly, the cancer outcomes are the same. So there's no compromise when it comes to how patients do with their disease, whether you get it robotic or whether you get it open. The next thing is oligometastatic disease. So what we're talking about here again is a level of disease that is low enough that we can treat it all, and that we can hopefully provide some sort of long-term benefit to patients that will override the temporary essentially suffering that we cause by some of these procedures. And histotripsy is one such procedure that has very little side effect in terms of complications to the patient. So I didn't go into this too much detail because I know there were some questions on it. I was going to answer them, but I can certainly expand now, is the sense that the way we do it here at NYU is that people come in, they get an ultrasound, what we call a screening ultrasound. I work with Dr. Silk, he's my colleague in interventional radiology, he's an ultrasound expert. And we work together on these. And what we'll do is patients will come in, we'll localize the lesion with ultrasound, and then we'll end up doing the procedure. The procedure takes anywhere from 1 to 2 hours. And then patients right now go home the next day because we like to get a CT scan the next morning just to make sure everything looks good, the patient's doing well, and the lesion's been completely treated. And then the most important thing I think for these folks is that because these patients generally have lesions that have come from other areas, they're oftentimes on multiple different therapies. And the important part is you don't need to disrupt those therapies. You can continue taking your systemic therapies, whether that's by a pill or whether that's by IV, and we can do this lithotripsy procedure or histotripsy procedure on that. And again, hopefully, if it bears out that this abscopal effect is the real deal, and again, by treating one lesion, we can essentially impact the treatment of others as well. So thank you so much for your time. I'm happy to answer any questions now. For the surgeon, much, much different. Laparoscopic surgery is a completely different way to do surgery compared to robotic and open surgery for that matter. What it is using is it puts a tool extension in between you and the patient. So you basically use these instruments that are extensions of your hands to make smaller incisions to go in and operate. It's essentially operating with kind of like chopsticks in a way. So it's a completely different way to operate. Whereas robotic surgery is the same thing, same small incision, but the end of the instruments are almost identical. And in fact, some would argue superior to your hands. One, there's no tremors. So the robot itself stops and prevents any tremors from happening. So you're as smooth as you can possibly be. The other thing is actually in terms of range of motion with your hand, the robot has greater motion than our natural hand does. So you can actually move things in a way to a greater degree than you can open and certainly laparoscopically as well. But ultimately laparoscopy in terms of pancreas resections, particularly for Whipple's, is definitely going to be falling out of favor and at one point will go away nearly completely. Removing the end part of the pancreas, those distal pancreatectomies, laparoscopy is still done in many scenarios for patients. We happen to prefer to do it robotically here. We think the outcomes are slightly better in terms of pain and things like that, but ultimately it is very fair to have it done robotically or laparoscopically for distal pancreatectomies. Histotripsy is for any cancer that is present in the liver. That's currently the FDA approval for it. So whether it's breast cancer that's spread to the liver, whether it's colon cancer that's spread to the liver, pancreas cancer that's spread to the liver, so on and so forth, or whether it's a lesion that started in the liver, all of those are potential candidates for histotripsy. As I mentioned, there's a trial going on at NYU to expand that to tumors that start in the kidneys. And I think in one day, in about 6 months to a year, certainly they're going to be expanding the trial to lesions that start in the pancreas. So certain less aggressive pancreas tumors will be available for that. But the hope is if this technology does prove to be as safe and as effective as we believe it will be, then certainly it'll expand to many other areas. The one major limitation for histotripsy right now is that it can partially go through the ribs, but it can't completely go through a rib. So if a lesion is directly behind a rib, that is a very difficult lesion to treat. And it's just because the energy that's required to get through the bone into the liver is a little bit higher than is currently tolerated by patients. And so, there's probably about a third of the liver or so that's currently off limit. Sometimes you can sneak in between ribs to treat lesions, but right now that's the greatest barrier that we're looking to overcome. So as we get better and better at understanding kind of the exact way pancreas cancer develops, we do certainly see a couple different components. There is a very strong genetic component to certain types of pancreas cancer. And the recommendation is for anybody with a diagnosis of pancreas cancer to get genetic testing, not just of the tumor itself, but of something we call germline, which is the genes that are passed down by your parents. So there's two types of genetic testing. There's the tumor itself that has a unique mutational profile that allowed it to become pancreas cancer. And then there are mutations that are passed down from generation to generation. So the tumor mutations are called somatic mutations. And then the germline mutations, those are the ones that you pass down. And everyone with cancer is recommended to get germline testing. there are a number of patients, it's about 15% or so of pancreas cancer patients that have some sort of familial association that we don't completely know yet. So for example, if your parent had it before the age of 50, we know that you're more likely to get it. We don't exactly know why, but we do see when you look at entire populations, when you see that a parent has had it at a younger age, it's much more likely that the child will get it. And so when we're talking about specifically pancreas cancer, these cysts are a much different story, but also there's ways to follow and genetic ways to evaluate that. But right now we are hopeful, and Dr. Wolf can certainly talk about this in terms of things like liquid biopsies and being ways to try to detect cancer before we can see it on the imaging. Right now, we don't have a great option for that yet. We are not great at getting this disease earlier, but we're certainly making progress on that. But the standard of care is genetic testing in everyone. And if somebody is at high risk, high enough risk for pancreas cancer, and they don't have it yet, we surveil them, which means we get imaging, and that can be rather with an MRI or something called an endoscopic ultrasound. We can get that 6 months to a year. It depends on the exact mutations they have and the other risk factors they have for disease.
And just to add a few comments to that, just so I don't have the contact information, but we have a whole program here for people who are at high risk of developing pancreatic cancer. So they're part of a family or live in an area where the risk is high, that even though you don't have a tumor, you can be evaluated by our group. And it's the same people you're talking to here, us and others, but it's run by Dr. Gonda. And we're happy to evaluate people and do the genetic testing when appropriate, and to follow individuals that need to be screened, and there's protocols for doing that. So those kind of services are available here, and there's several others around the country. Just a little bit about, again, the genetics, to expound on a little bit about what Brock said. I saw that there was something specifically about HNPCC or Lynch syndrome. And you are correct in that, yes, there is an increased risk of pancreas cancer. It's not one of the highest risk genetic syndromes for pancreatic cancer, but there is certainly a risk. I mean, obviously you need to be screened for colon cancers and some other types of tumors, but pancreas also needs to be considered. So there is a slightly risk, and that has to do, there are genetic tests. The simplest thing is to test if there's a tumor, to test for microsatellite instability. If it's high, then there's the chance it could be a Lynch associated tumor. Now, hopefully you get to the point where you've screened before it becomes a tumor, but then there are mismatch repair deficiencies. There's genes that can be potentially screened to look for that, to see if you're part of a Lynch kindred.
Certain genetic mutations, like for example, BRCA mutations, particularly BRCA2, which is associated with a higher rate of pancreas cancer. Patients with those specific mutations are sensitive to more specific types of chemotherapy. So, for example, the standard of care in that patient for chemotherapy would be to get FOLFIRINOX. They can also get something called a PARP inhibitor afterwards as well. So certainly the genetics does play a role in terms of prognosticating, meaning how well we think you'll do afterwards, but also in terms of what we call doing targeted type therapies or precision medicine. So basically offering specific types of therapy for patients with specific types of mutations. You can get access to it, as in if the ribs aren't in the way and the lesions are accessible, you can treat successively. So you can treat once and then see how the treatment goes. As long as the patient's doing well with their other therapies and things like that, you can treat another lesion. Right now, the biggest lesion we've treated up to is about 4 centimeters or so, but you can provide additional treatments for lesions a little bit bigger than that. And you can do it in successive treatment sessions. So there are opportunities to treat multiple different lesions at different time periods. Unlike a microwave ablation or these types of therapies that use thermal that you essentially use heat or microwaves to burn the tissue, the result of histotripsy is that the tumor is destroyed and essentially is absorbed. And what we see in most patients, 4 or 5 months down the line, is actually it's completely normal liver tissue there. Whereas the opposite is true with ablation. When you burn and you use heat for those, whether it's microwave or any other process, that burn mark persists over time. And so with histotripsy, you do see essentially liver parenchyma regeneration. So yes, you can treat successively.
Okay, all right. I specialize in radiation treatment for pancreatic cancer. Work closely with Dr. Wolfgang and Dr. Hewitt. So, I have a talk task today to follow two great talks. I think we're doing some exciting new things at NYU as far as the use of radiation goes. The indications for radiation generally, we're going to try to treat patients for definitive intent. Is to treat patients with localized disease, and after that, study close collaboration with surgery. At NYU to the credit of our researchers, a much higher proportion of patients here are considered resectable compared to at other centers across the country. But in some situations, the pancreas, the challenge with treating pancreatic tumors is that it's in close proximity to the blood vessels, especially the arteries. In some situations, we were trying to operate, Dr. Wolfgang and Dr. Hewitt, if they're not reconstructing, if they're, there's the risk that they may leave some microscopic disease behind. If those patients were, offering radiation before surgery to help, patients go for surgery, get a marginated recession, which, is the best possible outcome for patients. And in some situations after surgery, there's a microscopic disease residual remaining. And, we, try to knock that out with radiation. We have the tools now where we can really focus the radiation in a way that we couldn't historically. And the other issue is that, unfortunately, some patients are not resectable. And this is not necessarily because they're not technically resectable because of contact with the vessels. But in some situations, they have other medical comorbidities that prevent them from undergoing, a really complex surgery. And I think this is one of one of the challenges of radiation historically. We didn't treat those patients very well because we couldn't give as high of a radiation dose as we needed to in those situations because the tools we have been using for a long time have not, allowed us to do that. But, in the last year or so, we've come up with a new device, a new machine that's going to go live in the summer. So I want to talk about that. But before I do that, I want to explain, the typical workflow for radiation and how we conventionally treat patients and the challenge with that. So, and honestly, radiation is a very confusing topic. There's a lot of new terms, and a lot of my patients are coming to me to say, oh, what about cyberknife? What about protons? What about SBRT, IMRT? And it's hard to really understand, all the differences, what all those things mean. But, for most patients, what they're going to have as far as treatment goes is a high energy X-ray. And that X-ray is going to be shaped. Usually the tumor volumes that are designed for a patient prior to treatment, and it's shaped as it enters, it's the treatment head, and it's shaped to conform to the actual shape of the tumor in the pancreas. And the two ways generally that we treat patients, one is with something called stereotactic body radiation therapy. And we do that, we would do a really high dose each day in about 5 days, and that's it. And usually that's for tumors that are not too close to the small bowel or the stomach. So when you look at the pancreas, the stomach and the duodenum, they wrap around the pancreas, and those structures are very sensitive to radiation. So we can't give too much radiation to those structures without causing injury. And this is one of the downsides of, what we'd be able to do for radiation, but we're trying to change that. And if we cannot do SBRT, what we would do instead is do intensely modulated radiation therapy. And in that situation, we send out the treatment course to like 5 to 6 weeks. And we give a smaller dose each day so that the bowel and the duodenum can tolerate the radiation better. But we can still pack as much dose in as we need to control the tumor. So the problem with radiation right now is that it's not dynamic, it's not adaptive. So all of the planning process for patients happens before they come for treatment. And when they come for treatment, we can't really change the plan other than shifting, the radiation machine to align to the patient. And so, radiation actually has been around since the 1950s. But most of the technical advancements have only really happened the last 10 to 20 years. So the ability to deliver radiation is now, initial point where it's starting to shoot off. But for a long time, we were doing like X-rays with crayon markers back in the 50s and 60s. It was until like the 90s or 2000s where we started using CAT scans for radiation plating. And now we're able to, visualize the tumor during treatment, create, three-dimensional planes. So all of that has been changing over time. But the challenge still is that all of that plating, even though it's very sophisticated, it doesn't really account for what's happening during treatment. So this is what patients usually undergo before they get radiation treatment. This is a CAT scan, and we have, immobilization devices, and then we have to measure how much motion is actually happening in the tumor, so the pancreas is not stationary. When you're breathing in and out, the diaphragm is going up and down, and that causes the tumor to move. And also every day, the stomach and the bowel, they change in terms of the volume because they're filled with gas. When you're eating, then also causes the stomach to descend, that can cause the tumor to move. So we do have motion management strategies that we use to make sure that the tumor doesn't move too much during treatment, such as a breath hold, or we use like a special compression belt to make sure the tumor doesn't move. And then, when they come for treatment, this is what they usually see. So after all the plating stuff, through all the table and through all the couch, and then the treatment of the LIDAC hand is a leader accelerator. That's where the radiation beams come out. And then it comes out, and there's like a bunch of leaves inside the hand. So it moves all around the patient. And then as she does that, it's like continuously moving, and that's shaping the beams as it comes out. But as I've been talking about, the radiation is not really dynamic. So you see this scan here. This is a sample of a CAT scan acquired for plating before treatment. But when you're actually on the table, this is the kind of scan we see. So this is why for our patients, before they come for treatment, we place, metallic seeds in the pancreas called fiducials. And we use those fiducials to line up the patient. We capture what could be before treatment, and we shift it to make sure they're in the right spot. But we can't see the sharp tissue that well. The cold beam doesn't give us enough diagnostic quality to be able to see the tumor well enough, then actually adjust for it. And the second thing is that the cold beam is not actually on during treatment, so we're not seeing what's happening to the pancreas during radiation treatment. And the treatment for most patients is around 2 minutes long, so it could be moving. We have margins, hey, we make sure we cover it, but we can actually see what's happening and we can adjust for that. So this is, what we, want to do for our patients. So we have a machine that, went live last year. So for the last year, we've been actually treating patients, but only for patients with different types of tumors, like prostate cancer, for example. But my team, we've been working, hard the last few months to get this ready for pancreatic patients, and the plan is to start treating patients this summer. So the really, cool thing is that now instead of all the planning happening before treatment and none of the planning, accounting for the changes during the radiation treatment, all of that changes. So this is what's now going to happen every time the patient's on the table. So when they come in for the, radiation treatment, what we're going to be able to do is acquire a MRI in real time. And then we can actually see, the soft tissue, like the pancreatic tumor, the duodenum, the bowel, the stomach. Then we can adapt the plane that day while they're on the table. So we will create an all new radiation plane every day during treatment. And that should allow us to deliver a radiation dose that is historically higher than what we used to do. And, with the MRI, the other thing we can now do is we can acquire special sequences that allow us to see the heterogeneity of the tumor, the probably different areas of the tumor that we could use to decide the radiation dose, a different higher dose here and there that could potentially improve disease control. And then, while they're on the table, the other thing is that after we, adjust the blade, we have, our physics team and our dosimetry team. They work with me every time. We make sure the blade's safe and ready to go. But the really cool thing now is I want to show this video. So this is a patient's treatment that I was observing. So what you're looking at here are, MRI scans real time during treatment. And these are just three different blades. So the green lines here are just the target volumes. And this gray thing, I don't know if you can see my mouse, but that's a pancreatic tumor. So let me turn off the video.
Single.
It's a nice stuff.
So that's kind of the top of it. Yes. And then that.
All right, sorry, there was some audio there. But the tumor, you can see it's moving, during treatment. This is a very short video, but during the oral treatment, the MRI is on. Now, what's really cool about this is that this summer, we're getting new software that will allow us to gauge the beam. What that means is now we will draw the volumes that day. We will adjust it for each day of treatment. Then when the treatment starts, we're going to turn off the MRI, and that's going to track the tumor in real time. So as it moves in and out, if at any point in time it's outside of the boundary or another structure comes into the boundary, we will be able to stop the radiation beam. Then start it again when it's back in within the radiation boundaries we set. So now why that could change these for patients like you is that now we can deliver a higher dose of radiation and reduce the toxicity of, making sure that, the other structures are not getting too much radiation, but keep the pancreas amount of radiation that we historically couldn't. Because back in the day, if you look at this slide, you see here, so the red is like the tumor, right? That's the tumor volume. And then you see two different colors, blue and yellow. So yellow is a higher dose, blue is a lower dose. Now we can't push the yellow dose all the way to cover the tumor volume because the duodenum is right there. So if we did that, the risk of toxicity would be too high. But with the MRI, we can't do this. So you see this here, these are scales from 3 different days across treatment. The first session, the third session, fourth session. So for example, see this part right here, you see this blue line, there's nothing there near, the anterior part of the patient. But if you look at it on day 3, see there's bowel right there. So if we were not able to adapt the blade, the bowel would have seen the full dose that he saw on the first day. But now we're able to pull the dose off and create a new blade that day. And you're still able to deliver the amount of radiation watching the tumor. So on day 4, you see the bowel was moved again. So this is something that, really only started within the last year or so. And that I think is, very exciting for patients. So the other thing I want to talk about at the end. So I think Dr. Hewitt really summarized this very nicely. Oligometastatic patients are patients who have, or a subset of patients with metastatic disease that are usually, limited to maybe 1 up to maybe 5 sites. And the biology is very favorable to responding to systemic therapy. The tumor markers are controlled. And so, there's different, ways we define this population. So, Dr. Hewitt really to detail all this. So what I just wanted to add is that, we have a lot of different tools for local therapy. So we have surgical options, we have histotripsy, and then also we have radiation. So radiation can get to areas where, maybe other areas can't. For example, some patients have disease in the lungs or in the bone. We can still treat those tumors by using radiation. And then it deliver sometimes, the histotripsy device cannot visualize some tumors well because of the rib cage. But in those patients, we could offer them surgery or radiation. So radiation at the end of the day is a tool that can work closely, with, systemic therapy and other forms of local therapy to, provide the best outcomes for patients. All right, so I just want to summarize here, it's been long, if really for everyone, and I really appreciate you all, um, taking the time to hear us out and allow us to share these things with you. So, I just want to summarize and say that this summer we have a new machine called Electric Unity that's going to allow us to create dynamic, adaptive plays using real-time MRI scans taken every day during treatment. And we're trying to expand the indications for, definitive radiation therapy to include not only localized patients, but biologically favorable oligometastatic patients. All right, so that's all I have for you guys. I would say that surgery is still the standard of care. And, for all of our patients, the goal is to get them to surgery. And obviously, local therapy is only as good as systemic therapy. We have to make sure they get, the appropriate response to systemic therapy. They go for surgery. So Dr. Hewitt and Dr. Wolfgang have talked about this, and I think that's the standard of care. So we usually offer radiation in those situations to make sure that they go for surgery and have a successful outcome. Now, for people who are resectable, I think this is where radiation has been challenged, honestly. And that's because the tools we've been using have not allowed us to deal with the full amount of radiation. And I don't know if you would ever replace surgery, to be honest. But that's what we're gonna try. I mean, we should be trying for that. All of us, we should be trying to beat each other, right? Because that's what's making these better for the patients. So if one of these working better than the other, then that's what we're gonna do. We're gonna come up with, technical solutions to treating pancreatic cancer. If that's surgery, if that's radiation, we will try to come up with a solution.
And just a little bit to follow up on this is why it's great to work with the team. And obviously, you're just looking at a small part of the team that includes, medical oncologists who work with us, some of them online, or advanced practice, everybody who works as a team. It's hard to answer that in general because for some patients, where we all sit down and review those patients, the right and best thing for them is radiation. In some patients, the best thing is chemotherapy only. In some patients, it's surgery only. And in some patients, it's a combination of all three. And so it's everybody is treated uniquely, and all of the experts will sit down and determine in this specific case, in this specific person, what is the best treatment or series and sequence of treatments for this particular one. And so it's not about one being better than the other. It's having experienced clinicians in the field who have a bag of tricks and tools that we can use either as the only therapy or sequenced integrating with each other. And that's really one of the biggest revolutions in taking care of this, is not the individual fields, but functioning as a team. Again, I'm in the Department of Surgery, Brock's in the Department of Surgery, but we work and talk to Colin more than we do to a lot of his surgical colleagues, because we're all on a team, taking care of pancreas patients. And, we work together to come up with the right approach for every individual.
Some patients I've treated do have, peritoneal nodules. But I would say that, it really depends on how much disease there is in the peritoneum. If there is disease throughout, generally, we don't use radiation for those patients. It can't be a palliative tool in that setting if it's causing a lot of pain. If it's localized in a few areas, typically the answer is they go for surgery. I have treated one patient with a peritoneal nodule because that patient just was a surgical candidate for medical reasons. And, we use, imaging guidance to target the tumor with something called SBRT, and the patient actually did pretty well. But it's a challenging treatment because the bowel is all, very close to the peritoneum. It's moving around during treatment, so you could potentially injure the bowel. So if we have better tools like the MRI that might change these, we might be able to treat more patients like that. But it's also really hard to visualize how much disease. So the MRI, the cascades will always capture the full set. And you don't really see how much is there until you actually go in with a laparoscopic view, for example. So it's a tricky thing. And I would say generally the answer is no. And in some situations we have done it's, and it's been effective in that situation.
There's something too that is becoming more popular, certainly very limited in terms of how it's being used in pancreas cancer. There's something called HIPEC, And what that is essentially chemotherapy that not is through the veins, but is actually a liquid fluid, and we put it into the belly. And so it's not done a lot of places across the country. It's certainly still more what I would consider on the experimental side. But as Colin mentioned, for certain patients with very low disease, even peritoneal disease, you can give them repeated hypex over time. And what you do is when you go back in, if you can see there's a reduction or an elimination of disease burden, then again, that's favorable tumor biology. So there's some evidence to suggest that maybe you can target those patients for a little bit more aggressive in terms of their surgical management. But that's something we offer, but it's certainly, again, something more that is only done in highly selected patients.
Follow up on that too. Again, the importance of the team approach and the personalized care. So we do have a handful of patients in which we've done HIPEC. You know, the HIPEC now, I think it's becoming clear that there's a benefit in some disease types, much less clear and controversial in pancreatic cancer. But in certain subsets of pancreatic cancer, the mucinous subtype like colloid carcinoma or so-called mucinous non-cystic, and in patterns of recurrence where you get peritoneal only disease and you can potentially debulk that disease. It's not to the level of science yet, but we have done that in highly select patients and have had a few long-term survivors now that are years out who have no evidence of disease. So
yeah, there's something about the mucin that is a little bit better. Same type of thing, same type of reason behind IPMNs and MCNs. Tumors that are arising, pancreas cancers that arise from those types of cysts, on average, tend to do better than patients that don't have, that have tumors that arise not from those cysts.
So that's a very new radiation technique, and the theory behind it is that you're delivering the radiation at a, basically at a flash rate. So it's a really high grade of delivery. So right now, we treat radiation. I mean, it comes out very fast, but this is like just faster. And we know how to see, we're still learning a lot about it. There are a lot of theories that suggest it may be potentially more effective. Right now, there are no clinical trials that I know of. Usually flash to treat patients in practice, except for one case where they're treating skin cancers at the University of Cincinnati. And the reason behind that is because with flash, you're not able to treat tumors in depth. You're not able to get your tumors like the pancreas, for example, just based on the physics behind it. So you can't get those radiation beams to go far enough. But people are working on it. They said does it really do what we think it does? Basically, the premise behind it is that people think that the tumor responds differently than normal tissue. That normal tissue would not respond to flash the way it does to other types of radiation. And in theory, you could deliver such a high dose of radiation, and it would not affect the normal tissue. But that is just a theory. And all the studies right now are still in the preclinical phase. And I think that's something that hopefully, will pay out, and maybe we'll be able to start treating patients with that in the future if that, proves to be true. But there's still a lot of challenges that we still have to figure out. I don't think that's something that will happen for another 10 or 15 years, to be honest. I think the biggest thing that I tell patients, especially if that part of the bowel or stomach is not resected, the walls at the luminal structure can become very sensitive, and that can put them at risk for a fatal hemorrhage. I've seen this case. I had a patient that was a treated ear, but came from an outside institution, and they delivered a really high dose of radiation. And unfortunately, in that situation, the tumors was just right next to the duodenum, and the patient just kept pleading and pleading. And there was really, a way to stop it. That situation was a unfortunate situation. It doesn't happen very often. But this is why you have to be very careful in the plating process. And this is why we spend, 2 weeks plating out the radiation, shaping the beams. And then, this is also why we're trying to come up with new ways to track the tumor in real time, and also see all those other structures, make sure they don't get too much radiation. So that's really the main thing I focus on. That's the main side effect from radiation therapy that I worry about that keeps me up.